We'll finish out trial designs here, starting at stepping stone number 5, with the common designs of large phase clinical trials. Keep in mind that large can be a relative term. If you're looking at a rare disease, a large clinical trial may be 100 participants. If you're looking at a common issue, it could be thousands. So this is all disease specific. But across all sizes of studies, you want to remember to not overcomplicate matters. The design should fit your objectives. Don't simply pick a neat design for the sake of completing the trial, or that it's a hot button or hot topic, new to the scene clinical trial. There are many, many questions that can be answered very simply and very straightforward. So keep that in mind when you're designing. What you want ultimately at the end is to be able to answer your question clearly and concisely, and overcomplicated designs can really muddy those interpretations. Don't forget about the blinding or the masking of your study. Is it single, double, or triple? Intervention, how is it delivered and how is it packaged? Those will have some impact on how you assess your outcomes and when you assess them. So the most common design is a simple parallel design, where you have a screening phase followed by randomization to treatment arm 1 and treatment arm 2. This could, of course, be a surgical intervention, a device, a behavioral intervention, but you just have 2 treatment arms. You have follow-up time, and you have your final endpoint assessment. These are very easy. They can extend to multiple treatment arms, so you could have a 3 or 4 parallel arm study. It does not require one-to-one allocation, meaning that you do not have to have one person for treatment A and one person for treatment 2. If you have sufficient information about treatment 2, you may want to do a 2-to-1 randomization where you put 2 people in the new treatment for every 1 person in the existing treatment. The cons of simple parallel designs is that they usually require a larger amount of people, and you need balanced design by covariate. So if it's very simple, you may end up with a more heterogeneous group of people in each treatment arm. That can make your variance larger. That will in turn make your statistical tests a little bit more difficult to reach significance. So if you're just simply doing treatment 1, treatment 2, be aware of that factor. Crossover designs are very clear as well. They do cross over. Similar screening and randomization, similar allocation to intervention 1 and intervention 2. They're followed until the endpoint. Then there is a washout period where you let whatever impact that intervention had go away. That means that the disease process or whatever you're studying should come back to the baseline level. Then everyone that was on arm 1 before goes to arm 2, and everyone that was arm 2 before goes to arm 1. So the considerations here is that you can test multiple treatments in succession. You can use a lower number of participants because everyone is serving as their own control. You need to make sure you've completed your blocks if you want to do a complete crossover. And so you have to be careful about dropout here, because you don't want everyone to complete the first block and not complete the second block. Then you're back to a simple parallel design and you may not have the power to answer your question. You may have accumulated effects that won't go away with washout. So this is where the pharmacodynamics and pharmacokinetics come in. How long does it take for a drug to leave the system, and how long are the lasting effects of that intervention before people return to baseline? And they can take longer, of course, because you're running people through 2 phases of a study instead of a single phase. This is best in chronic conditions. So if your first block of treatments cures or alleviates the condition, there's no crossover. You would not be able to measure anything in subsequent phases if people were cured. So if you think about migraines, that's a chronic condition where you do a short-term treatment 1, wait a month, and then try treatment 2 and see if that works any better. This is very good for bioequivalence trials, so you can actually measure pharmacology with each patient as their own control as well. So if you are, in fact, looking at the pharmacodynamics and the pharmacokinetics of the drug and you know the half-life, then you know the washout period very precisely. There's something called cluster randomized trials, and these can be parallel or crossover. This isn't so much the design of how you are testing the treatments. This is how you're randomizing people. So you're randomizing units instead of individual people. So if you think about students in a classroom, or if you're doing group therapy, behavioral interventions, you can't randomize individual people within a group scenario. You would have to randomize the group to do this behavioral intervention and then randomize another group to do the other behavioral intervention. So these are called clusters. You're randomizing in clusters. This is much harder to control when you're randomizing as groups because, of course, you can't necessarily control the individuals within that group, particularly if the behavioral intervention is readily available. So if you're looking at, group therapy versus Nicorette, there's nothing to keep the people in the group therapy sessions from also using Nicorette. So just be mindful that it's harder to control when you're cluster randomizing. And this is much more statistically involved, and there are many factors to consider. Factorial designs are very common. So this is where there are combinations of treatments. So an active and a placebo, a low dose or a high dose, or early intervention versus late intervention. And so you have two options for each of your intervention arms. So if you think about an active treatment A and an active treatment B versus placebo A and placebo B, you'd get 4 combinations here. So we'd have our active group, our active A, our placebo B, our placebo A and our active B, and our placebo A and our placebo B. So 2 squared or 2 factorial gives you 4 groups, 2 cubed or 3 factorial gives you 8 groups. Considerations with factorials is that treatments must be able to be administered in combination. If there is a placebo option for both, a placebo group must be ethical. A lot of times you can no longer administer a full placebo group, and that's where we get into a partial factorial, or we'll talk about that in just 1 minute. You need to have a valid scientific interest in the combination. An example is that treatments with different mechanisms of action are more suitable candidates for a factorial clinical trial. So you'd want to have something that's acting on the brain as well as something that's acting on, say, the liver, but you wouldn't want to administer 2 different medications that are both acting on the brain. So you have to be very careful about the mechanisms of action of those medications and what the purpose is. And you also have to be aware if there are placebo options for both. Also consider interactions and power calculations. So you would want to fit the full model. So A plus B plus A times B. That is your statistical model interaction. You have to have all 4 groups present to fit this model. Partial factorials, as I mentioned, is when the full interaction can't be completed or analyzed. There is no placebo group. So partial factorial can make interactions and mate effects impossible to tease out from one another. You cannot fit the statistical model with the interaction because you would end up with zeros. There would be no people in the one of the A times B groups. That makes it mathematically impossible to fit. So you would end up with a 3-arm ANOVA. You'd have group A, which is the combination, group B, which is the one single agent, and group C, which is the other single agent. You would not be able to fit the full factorial. But that's okay because the placebo option may not be of interest even if it's ethically sound. So if you're combining pain reliever and sleep medication into a single pill, you don't want to give somebody placebo. You're actually only interested if the pain reliever plus the sleep medication is better than the pain reliever alone, is better than the sleep medication alone. And it turns out that this is how patents can get extended. If you can find a combination medication and test that, you may be able to keep the proprietary patent on one of your medications. So those are the common designs that we have for large phase clinical trials. You will see also in large phase clinical trials that people will use adaptive designs so that they will stop and look at their data at pre-specified time points and adapt or change the sample size based upon information collected. But the primary design would stay the same. And that's really important to remember. What you pick in your design, be it parallel, crossover, factorial, partial factorial, cluster randomized, that will be your design throughout the entire study, regardless of whatever else that you may alter during that time period. Your design will stay the same. So general considerations. Think about the timing of screening. Is there a need for multiple screening visits or a lead-in period? What is your primary outcome of interest? Does it have a learning curve? So you need to administer a test a couple of times before participants get the hang of it, before you make your baseline assessment. How far apart do your screening and randomization visits need to be, or can they occur on the same day? What data needs to be collected before randomization can occur? That will also determine your screening period. How is your treatment administered? How long does the intervention take? Is it a shot? Is it daily pills? Is it infusion? Is it surgery? Is it behavioral? How long does it take to perform that intervention? Because you need to measure people before the intervention. You may need to monitor them during the administration. So if it's an infusion, you simply can't just give them an infusion and let them leave. They need to be monitored for several hours. If it's surgical, they'll be in the hospital. So how long does it take for the treatment to fully take effect? Do you need to titrate medication? Are there gastrointestinal issues if you hit someone with a full dose and you need to titrate up to a full dose? So you wouldn't start your outcome assessment until they've hit the full dose of medication. And will people be given an active treatment following a period of placebo treatment? So is this a step up or, again, titration design? That is, are you waiting for somebody to hit a threshold of worsening before you give them treatment? So is there any placebo time for your participants before they get active time? So you have to think about these things because they will impact where your baseline measure is and how much variability you have at your baseline measure. And that, of course, directly impacts your change score, which impacts the comparison of the changes in your treatment arms. So all of these things need to be considered when you are designing a study. Think about your question, your primary question, 1, 2, 3 tops primary questions that you want to address with this data collection. Keep it simple, and then think about how this is functionally going to be made operational. Remember, the good design and goals from Piantadosi. Analysis follows design. What is the goal? What happens in real life? What would be meaningful for this population? What is the simplest way to answer your question? And remember, statistics cannot save bad design, so it's better to start with a good design first.